morning. I'm Michelle Lavander, Director of the Center for Health Journalism at the University of Southern California's Annenberg School. Thank you for joining us today for our Health Matters webinar, Election Fallout: Where Does U.S. Healthcare Go From Here? Offered thanks to generous grants from the Commonwealth Fund and the National Institute of Healthcare Management Foundation. Voters told pollsters as they headed into this midterm election that healthcare was one of their top priorities as they cast their vote. In many ways, this election has proved to be as much a referendum on healthcare policy as it is on the presidency. With Republicans more firmly in control of the Senate and a Democratic majority in the House, what developments can we expect to emerge in the coming year in this crucial policy arena? We've asked two of the nation's leading experts to weigh in, a Republican and a Democrat, so that you can gain information that will help you inform your audiences. Jean Lambrou is a senior fellow at the Century Foundation and an adjunct professor at the NYU Wagner Graduate School of Public Service. Previously, she served in the Obama administration as the director of the Office of Health Reform at the U.S. Department of Health and Human Services. There, she coordinated work toward the passage and implementation of the Affordable Care Act. Before that, she worked at the White House as the Deputy Assistant to the President for Health Policy, helping execute the President's health policy agenda. Lan-Hee Chen, our other speaker, is a research fellow at the Hoover Institution and director of domestic policy studies and lecturer at Stanford Law School. His current research focuses on health policy, retirement security, campaigns and elections, and California policy and politics. He has advised 4 presidential campaigns on health policy, including the Romney-Ryan campaign, Senator Marco Rubio's 2016 presidential bid, and as a health policy advisor to the Bush-Cheney reelection campaign in 2004. He has also served as a senior advisor on policy to the National Republican Senatorial Committee. Before we get started, I wanted to share a few operating procedures. We'll hear first from our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have more than 200 people signed up for the webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. You can tweet about this webinar at the hashtag midtermhealth. So I'm going to turn now to our two experts, Jean and Lan-Hee. To get us started, I just wanted to share a quote from two political writers who described a sea change in Americans' attitudes on healthcare in this election. They say Tuesday's results showed a fundamental shift. A bipartisan majority of the public now believes healthcare is a right and that the federal government should play a role in helping people access insurance. Do the two of you agree? And what does this election mean for U.S. health policy writ large? We'll start out with you, Lan-Hee.
I do think that Tuesday's election was an indication of where things are headed in terms of how the American public views healthcare. And this is a change that I think has been underway for several years. But in particular, what I think we saw, first of all, was a great number of Americans who argue or who believe that the federal government should play an active role in the healthcare system. And I think that is an important resolution in some ways, because it speaks to the fundamental conflict that I think conservatives and liberals have had over healthcare policy for some number of years. It doesn't necessarily mean that voters agree the federal government should do everything. We can talk a little bit about what that might mean in terms of the healthcare policy going forward. But certainly the notion, for example, that the federal government ought to provide protections against insurers discriminating on the basis of pre-existing health conditions, that was a significant issue in the election on Tuesday. And I do think that in some ways there was a resolution around the value of the federal government providing that measure of protection. I would say that the politics of this have gotten even more complicated, if that's possible, for Republicans in this sense. For many years, the argument quite simply was Republicans wanted to repeal and in some fashion replace the Affordable Care Act. With what happened in 2017, That obviously changed in some ways. For Republicans, I think the question now is, do they go back to health care at all? Do they try and do something here in these next 2 years with divided control of the Congress and President Trump in office? Do Republicans try to do something on health care reform? My view is it's somewhat inevitable. I think Republicans will have to return to this issue. The question is in what manner and how, and whether they'll work with Democrats to shore up the Affordable Care Act or whether they'll try and go in their own direction. My own view is that a bipartisan consensus is less likely in the short run, particularly on the specific issues around coverage and the ACA. We could talk about drug pricing. I think there might be some agreement around drug pricing, but fundamentally, if you look at the numbers coming out of the election on Tuesday, it's still clear that Republicans and Democrats feel differently about the ACA. And Republicans, I think, by and large, are going to have pressure to respond to how their electorate still feels about the ACA and what they think of the ACA, while at the same time ensuring that that they preserve some of the more popular components of it. So I do think Republicans will look at the ACA again. I think they will try to figure out how to address it in these next 2 years. Whether they do it as comprehensively or try to do it as comprehensively as they did in 2017 is an open question. But they certainly cannot leave healthcare exactly where it is now. Politically, I think going into 2020, that would be perilous, not just for Republicans in Congress, but potentially for President Trump as well. So Tuesday's election was significant. I think there were a lot of important signals sent. But at this point, I think there is much less resolved than unresolved as we think about how the legislative pathway forward looks.
And I agree with a fair amount of what Lonnie said, which is there is a disagreement over the means and the ways and the how we ensure all people have affordable, accessible coverage, especially those people who are vulnerable. But I might go back and argue that the goal, the idea that there's a newfound premise and belief that all Americans should have these protections, belies the fact that this has been something that's been high in public support for decades. It was something that led to the state of Massachusetts passing its reforms in the 2000s, to the Affordable Care Act passing in the first place, and it was the motivating force last year, which spilled into this year's midterm election, behind the defense of the parts of the system, because it's no longer a law or a bill, it is the system, the defense of those parts that people felt were working and were valuable. All that said, I think this larger debate about the role of government will continue into the 2020 presidential election. There's a clear contrast in visions between Republicans who trust states and cap funding and think flexibility and innovation may solve these problems versus Democrats who are looking at building on the Affordable Care Act, expanding Medicare, increasing the role of government. That debate will continue on a different playing field, on a different battleground, which is the 2020 presidential election. But in the meantime, I would not dismiss what is about to happen. You have a new Congress with a lot of energy on healthcare coming in. Certainly, some things won't happen. There won't be a return to the repeal and replace debate that happened in the last 2 years. But you will certainly hear more and see more about protecting people with pre-existing conditions, making prescription drugs more affordable, trying to get at the overall affordability issue, because a lot of dissatisfaction is driven by people who just simply can't afford their medicine or their health insurance. And I think there can be an agenda that is not only a signaling agenda about where the health system should go, but a practical one. You look for what are the day after messages, and President Trump in his press conference talked about trying to find common ground on prescription drug pricing. Senator McConnell talked about bipartisan fixes to Obamacare. There is a possibility in this coming Congress for concrete change to happen.
So, Lanhi, I wanted to ask you to follow up on what Jean said. She's just laid out some of the blueprint for Democrats, and you've said Republicans can't leave it how it is now. So, how might this play out with these emboldened Democrats coming into office and Republicans who are maybe feeling a little bit bruised on this issue?
Well, look, I think that the challenge is going to be, to a certain degree, what Republicans expect um, they would handle via the Senate, which obviously they'll still have control of, versus some kind of actual unified piece of legislation that gets to President Trump. I think in terms of Republicans not being able to leave things as they are, the way I view it is that they're going to have to pursue some kind of legislation that sets a marker down for 2020, that sets a marker down as they move forward. Now, whether that actually ends up getting to the president's desk is a separate question. Obviously, I think very little ends up getting to the president's desk, generally speaking, in an era of divided control of the two chambers of Congress. That having been said, I think Republicans on the Senate side are acutely aware of the fact that if they do not address healthcare in some way, what we're left with is the aftermath of the 2017 repeal and replace debate, which was unsatisfactory from a variety of perspectives. First of all, for a conservative perspective, because they didn't get to yes on a single set of policies. But politically, you saw the challenge is you're left with a bunch of votes that Democrats are able to use to bludgeon Republicans on this question of pre-existing health conditions, which is, in my mind, a very small component of what the ACA is about. And so I think for Republicans, the big challenge will be how do they address, as Jean mentioned, I think state innovation is the frame through which we should see future Republican action on health reform. How do they articulate an agenda that basically uses state innovation as the chassis, if you will, for future reforms? I think if you look back to the end of the 2017 repeal and replace debate, you will recall that Senators Graham, Cassidy, Heller, and Johnson put together a set of proposals around the general notion that states ought to be able to have more flexibility. I think that will be the baseline off which Republicans are going to operate here over the next couple of years. And I do think there's a possibility on the Senate side, at least, they could coalesce behind a set of reforms that would be based on that theme, the theme of state innovation. Now, obviously, it's not going to get to the president's desk because the House will never sign off on it. That doesn't mean that the Senate won't do it just for the purpose of having done something that Republicans can then campaign on in 2020, potentially, whether it's for the Congress or whether it's President Trump. So I would temper the possibility that there is actually going to be some reform that will pass the Congress and get to the president's desk. Yes, perhaps a narrow set of agreements on market stabilization of the ACA or something around drug pricing. But in terms of the broader question of what to do with the framework of the ACA, I think Republicans would be remiss to simply leave things as they are and not just address it in some way, or at least be able to demonstrate to voters that they tried successfully to articulate an alternative.
Jean, did you want to weigh in on this?
I would only add that there are going to be two currents that run through the next year that may or may not affect this larger question about what Republicans are for in the big picture. One is, putting aside Congress, the executive branch is powerful and they will continue to take actions. Just yesterday, 4 different policies were released at 4 o'clock on abortion policy, and that's going to cause angst and activity. There's this Texas case, Texas versus US, in which 20, I think now 19 attorneys general are suing to say the individual mandate's unconstitutional, there's no severability clause, the whole law should fall. The Department of Justice is not defending the constitutionality of the law, but saying only those pre-existing condition protections should fall. That there's going to be a decision on that any day. That could affect this landscape. There's a lawsuit on the short-term plans that are being sold now. There's a new health reimbursement arrangement rule that would potentially promote short-term plans. So I think the 2020 debate certainly will be along the parameters and contours that Lonnie suggested, but I think the actual details may be affected by ongoing trench warfare on the executive branch side with, going back to, what does it mean to have a Democratic House? It means potential legislation to roll back some of these executive actions. potential appropriations riders, which would potentially freeze in place existing policies. It could mean oversight in hearings, which, trust me, having been on the other side of this, accountability matters. It makes an administration think twice, if not slow down, when it's taking executive actions that push the boundary. And, the House itself can potentially launch litigation and sue. As a reminder, House v. Burwell was a case in which the Republican House sued the administration, saying we inappropriately paid for cost-sharing subsidies, and that started wending its way through the courts before the president decided to stop those payments. So I do think that, watching kind of the near-term jockeying is important, because it suggests that this recent hard-fought debate where everybody seemed to walk out of the election saying, of course we care for people with pre-existing conditions, may be premature.
So, shortly after the election, Mitch McConnell said that he thought that there would be room for some small fixes and compromises that could be bipartisan on a healthcare policy. And Lonnie, you mentioned a few things that are really issues that have dominated the headlines: market stabilization, drug pricing. There's issues about hospitals' financial stability for handling, a higher burden of sick patients, so who might not have insurance. So I'm wondering, do you think, either of you, that there could be some fixes, and would those bring some stability to pricing in healthcare premiums? What might you anticipate?
I'll go first this time. Lonnie already mentioned a fair number of them. Certainly last year there were bipartisan bills that included reinsurance to offset the cost of high-cost claims. There's bipartisan support for improved outreach funding to make sure that people know about their coverage options and sign up for coverage. Some streamlining of state innovation waivers was also in the mix. I think you may see more and more robust ideas this year, like trying to take the cap off of premium tax credits at 400% of poverty. That's an artificial limit that basically says below that you pay a certain percent of your income for premiums, but above it you don't. That's an idea that has been out there that could become part of the mix. Trying to promote competition in areas with few health insurance companies. I think the data clearly show that when there's more insurers in a particular area, premiums are lower. There are different ideas on how to do that, from, tying participation in Medicare Advantage or Medicaid managed care to participation in the marketplace, to potentially giving issuers in provider shortage areas or places where there's monopolies Medicare type prices to lower prices. There's ideas out there for how do you target high cost areas. And I think those relatively new set of ideas may be injected into last year's or last Congress's bipartisan bills. So there's a good array to choose from.
Yeah, I mean, I think, look, I think Jean outlined all of the different possibilities quite well. I would just say that there is going to be at some point a discussion about what happens after 2019. I mean, obviously 2019, we've seen some mitigation in premium increases, and the marketplace looks steadier in 2019 than it has in some number of years. It probably will change given the complexities around repeal of the individual mandate that came with the 2017 tax law. And everyone knows it's coming. Everyone knows it's out there, and the desire to get something done, I think, to create that stability in the marketplace for the 2020 plan year will be there. And so I would say, is it a first 6 months of 2019 proposition? Probably not. Congress usually doesn't do something until they absolutely have to do it. So I would anticipate this being a discussion we have probably in the third or fourth quarter of next year. But there will be some demand that will be placed on both Republicans and Democrats to address some of these questions around the stability of the individual market as we begin to see the effectuation of the repeal of the penalty associated with the individual mandate.
And you make some really interesting points. How does the introduction of these short-term insurance plans play into all this? What do you see coming from that as we look at the stability of these markets?
Well, look, I mean, I think that the short-term limited duration plans uh, are effective for a small number of people. And I think for those number of people for whom it is effective, it is an effective mechanism, which is why I generally believe that opening the marketplace up and creating additional optionality made sense. But the idea that short-term limited duration plans are going to solve the market stability problem, I think, is a little bit far-fetched. And I don't think that that's a credible position that even some of the administration would take. What I would say is it is part of a suite of administrative reforms, to Gene's point, that the administration is using to make a case around how it would implement the ACA in a way that's more market friendly. We can we can have a debate about whether that's generally positive or negative, but I will say that short-term limited duration plans are one part of the administration's broader strategy on this. So, like I said, I don't think it's going to be a unicorn solution. I don't think it's good for everybody, but I think for some limited number of people in some states, it does create optionality that makes sense.
Yeah, and just as a reminder, these are plans that are basically not subject to any federal minimums. They can deny people coverage who have pre-existing conditions, medically underwrite, rescind coverage if somebody has not committed fraud on their application, carve out benefits, have unlimited, annual caps. So they really have no regulations. So their risk is such that even the administration doesn't disagree that for people who join those plans, they may have coverage and they have warning labels on them that is potentially not there when they need it. And for people who remain in compliant plans, it will drive the premiums up. To Lonnie's point, the big question is how many people will sign up for them. And people are worried. If you look at a recent consulting report found that there are 8 plans, short-term plans, being sold for every one individual market plan in this open enrollment. We've seen the big 5, a couple of the big 5 insurance companies, Aetna and United Health, have said they're going into this area. They're not in ACA compliant marketplaces, so they have no conflict there, and they have the resources to really market these plans. And the administration itself continues to try to promote them in different ways. So just in the last 2 weeks, they released Section 1332 State Innovation Waiver Guidance that suggests they'll count short-term plans as coverage in the test of whether this waiver meets the required guardrails. And they indicated in their press call that they would potentially approve state applications that would allow taxpayer dollars to subsidize short-term plans. Similarly, in the health reimbursement arrangement proposed rule that came out, there is a accepted benefit, HRA, that could be used, up to $1,800 could be used for short-term limited duration plans. So the prevalence of these plans could become a lot higher if all of a sudden taxpayer dollar or employer dollars flow to them. And I do think it's a big risk to a stable insurance market when you have 2 parallel markets operating under different rules, where healthy people can get a cheaper deal until they need health care in one, and the insurers selling the compliant plans remain in the other.
So, as Lanhi mentioned, there's a big story to be told about the states. But before we do that, I wanted to come back to one of the earlier points we talked about, which is just what can happen administratively. As we saw in the Obama administration, when there are obstacles in Congress and when there's gridlock, there's a big temptation to turn to administrative remedies. And are there some additional things that you see happening out of the Trump administration that could continue on making some fundamental changes along the lines of what you just described, Gene, with the short-term insurance plans, and also how might Democrats respond to those efforts?
Yeah, I mean, I would look to some of the discussion around Section 1332, which is the ACA innovation waiver, state innovation waiver provision The administration did come out with guidance, which I thought was appropriate guidance given how restrictive the previous administration was with respect to really, I think, fulfilling the purpose of this provision. I do think that what you're going to see is you're going to see this administration, the Trump administration, maybe put out some more model guidance around what some Section 1332 acceptable waiver plans might be. Previously, until just a few weeks ago, the administration basically had only blessed a reinsurance model, similar to what Alaska and Minnesota have attempted. My guess is you're going to see them probably come out with some more thinking around, okay, if you were going to use a 1332 in a more robust way, what might that look like? Now, there are still limits. Obviously, there are statutory limits to what the administration can do here. 1332 does require coverage at least as comprehensive, at least as cost effective, and at least as widespread as that provided for via the ACA. And that's not going to change absent congressional action. Now, there's a separate question whether Congress might choose to take this up and if there's some bipartisan consensus around that. Putting that aside for the moment, I do think the administration has the administrative leeway and certainly the interest in defining a little bit more carefully what some other options for states might be. Because as I said previously and to this point, the 1332 mechanism has been utilized in a quite limited fashion. In one case, to essentially allow a state to enforce an existing employer mandate, that was Hawaii, and in several other cases to institute reinsurance type arrangements that ideally would lower cost in the individual market in certain states. So the question is, what does 1332 2.0 look like? And I do think the administration could seek to release additional guidance in that area in a relatively short period of time.
And I may note that this is not going to necessarily go unchallenged. If you look at what the administration did on Medicaid work requirements, the Kentucky waiver is now enjoined, and there's a lawsuit in the Arkansas waiver. I think people looking closely at this 1332 guidance wonder if they really could make the kind of interpretations that they're making in this guidance. And trust me, anytime state officials or federal officials are worried about litigation, it could slow things down. So I'm not positive what kind of pathway this truly is going to be without a legislative change. But I think, there's a regulatory agenda that the administration put up, and it foreshadows other changes that could potentially affect people with pre-existing conditions. One item on the regulatory agenda is to provide more flexibility for so-called grandfathered plans. That was a statutory provision of the Affordable Care Act that allowed plans sold or in effect on March 23rd, 2010 to be renewed unless they significantly change, in which case they have to adopt all the ACA regulations. The fact that there's now for the first time a proposal to change that 2010 rule to allow for more flexibility indicates that there's more on the horizon in terms of administration actions to try to create workarounds to the Affordable Care Act. And note that any day we'll see the proposed notice of benefit and payment parameters for the marketplace for 2020, and typically that has in it a raft of policies, and I think people are closely looking for the content of that rule when it comes out.
Healthcare is in many ways a local story or a regional story, and this election was a vivid reminder that states are key players in health reform. We saw 3 states electorates voting Tuesday to expand their Medicaid programs, which will extend coverage to an estimated 325,000 low-income Americans, and 1 state, Montana, voting against continuing the Medicaid expansion. What lessons do you see from this election and where we're going with the Medicaid expansion?
Sure, and I may take this to do a broader lesson from this election, because going back to the original question about what do people prioritize in our healthcare system, I think both in these ballot initiatives as well as in this debate over pre-existing condition protections, people use the small d democratic process to let their voices be heard. And I think that's an important matter. So continuing down the state pathway, it's interesting to not just look at the ballot initiatives and the governors who are elected who said that they would expand Medicaid. There's also the composition of state legislatures. So in the state of Maine, which has struggled to implement this ballot initiative last year. The governor and the legislature are now committed to doing so. In states like North Carolina, the supermajorities the state legislature no longer has a Republican supermajority, which gives the governor, who has committed to working with its legislature to expand Medicaid, some more leeway and leverage. So I do think that we'll see a lot more activity, both on Medicaid, but I also want to go back to insurance reforms. One of the interesting federalism stories out there is what states have been doing who are trying to counteract some of these policies, like short-term limited duration plans or association health plans. They're passing their own laws, their own regulations to counteract them. States like New Jersey, in their 1332 state innovation waiver, they're using a restoration of the penalty for the individual mandate to fund their share of reinsurance in New Jersey. And as a reminder, their average premiums for 2019 dropped by 12% going into 2019. And I think you'll see more of this divergence between states that are supportive of the Affordable Care Act, take the reins and implement it, and those that don't. So I do think the federalism story is not just about the big waivers, 1115, 1332, and big ballot initiatives or changes in the composition of their governments, but it's also kind of these other types of reforms that are happening at the state level, to say nothing of drug pricing, which is also a hotbed of activity at the state level.
Yeah, I think those are very astute observations. I would just say that on Medicaid expansion specifically, just to get to the politics of this for a minute, I think it's going to be increasingly difficult for a number of these states that have not implemented the Medicaid expansion to continue in that posture. Now, obviously, you would go to a state like Texas. A lot of people have sort of said, well, is Texas a state where we might potentially see some change? In the short run, the answer is probably no, but that doesn't mean that there won't be, to Jean's point, this public discourse around how to use democratic processes, whether it's an initiative process. And I'm not familiar enough with Texas state law to know whether this is an option or not, but certainly you saw it in Utah, you saw it in Idaho, two states, Utah maybe a little bit less so than Idaho, two states where the likelihood of pursuing Medicaid expansion was probably pretty low from the perspective of state leadership. But voters made it clear that this was something that they cared about. And I just think that political pressure, coupled with the fiscal pressure that states continue to face, potentially as we head toward some kind of economic downturn in 2019 or 2020, I think those pressures combined will make it more likely that Medicaid expansion comes on the table, even in states that we may not have thought it would come on the table on. So it's a combination of the shifting nature of state governments, the fact that there are more Democratic governors, but also this fact that, nothing imminent in that regard, but the fact that the composition of some of these legislatures is changing, but also the fact that people are seeing they can avail themselves of public initiative processes to force policy change. I think the combination of those creates some interesting opportunities for Medicaid expansion in the coming years.
And Lonnie, you're in California, in Palo Alto at Stanford, and the state has just elected a new, very liberal Democrat, Gavin Newsom, as governor. California's been called the resistance, and there's been some talk floated around about some very interesting propositions. One is this whole idea of Medicare for all and debate about its affordability or feasibility for the state. But the main critic of that, a Democrat, lost in the primary. And then there's been a measure that's been introduced repeatedly in the legislature that would go from what is currently law, which is extending Medicaid for children, to extending it to undocumented adults, which would be quite extraordinary. What do you see coming out of California, and would it set a new direction for state innovation?
Well, it's interesting. If you had said, 4 or 5 years ago that Jerry Brown was going to be the right wall, the right check on a very active legislature here in California, progressive legislature, I would have said you were crazy. But that's kind of what's happened. Governor Brown has been, in my mind, a pretty reasonable voice on some of these questions. the question really is, what is Gavin Newsom going to do? And I think the answer is we don't really know yet. I mean, there are elements of his record that are obviously very progressive, elements of his rhetoric that are very progressive, but he has not wholeheartedly embraced the notion of trying to move California in the single payer direction. I mean, he's expressed some skepticism in various points in his career. He's obviously spent time in the private sector and has a pretty diverse background. So I guess the short answer is I don't exactly know where the governor is going to be, if he's going to be forced to the left by some of his more progressive constituencies, or if he's going to see himself as sort of the person that needs to provide some element of moderation to the process. There's no question, though, that public opinion in California skews towards some of these progressive reforms, whether it's moving California toward a more single-payer type system, whether that's a Medicare, more likely something with the Medicaid program in California, or whether it's expanding access to Medicaid to undocumented immigrants. I tend to think the latter, the expansion of Medicaid to undocumented immigrants, is actually probably a more likely outcome than a really fundamental shift in the system here in California, at least within the next couple of years. But we'll have to see what happens with Governor-elect Newsom, and what he decides to do. I just think there's a lot of question marks. I mean, I think a lot of people wondered what Jerry Brown would do when he came back into office for 2.0. And I think he pleasantly surprised the business community in California. I think he pleasantly surprised a lot of center-right people here in California, because he was, I think, a bulwark against some more progressive change. Whether Governor Newsom will espouse the same kind of set of principles, we'll see. But I tend to think that a completely leftward lurch toward some kind of single payer system is still very much unlikely, even here in California.
And I would only add that for a state to take on this prospect of a single payer in and of itself is daunting. People may remember that Vermont tried to do this 4 or 5 years ago in the run-up to the first year of 1332 state innovation waivers being approved, and they hit roadblocks of the challenges of how do you deal with employers that span the borders between Vermont, Massachusetts, and New Hampshire. Will people really support the kind of level of payroll tax that it would take to replace premiums and most copays? So they abandoned their effort, and that's a small, fairly homogeneous healthcare and demographic state, economic state, compared to California, which presents a lot more complexity. So putting aside the will, the way forward on this is a challenge. All that said, I will say that we look at our history of health reform, and many of the ideas that eventually end up being passed into law successfully have been tried out at the state level. So I think this idea of looking closely at what California has done to have a pretty low uninsured rate and relatively low costs is important. Seeing what other states can be doing, again, going back to drug pricing, I'm excited by the prospects of some of the governors and state activities giving a roadmap to Congress on what else might be possible in terms of cost control and drugs. And I'm tracking this interesting policymaker in North Carolina who is trying to lower state employee health costs by using some variant on Medicare rates for the state employee health plan program as a way to rein in costs. I mean, these are small but signal kind of initiatives that I think we all do better when we see what happens with them, see their results, and then learn from those results.
It's been said that the next election starts now. So what do these results portend for the 2020 presidential election?
Well, I've always thought that we were going to have a pretty robust debate about some kind of single payer Medicare for all type system here in the United States at some point. And I tend to think that that time has arrived, in part because the political dynamic around 2020 is the interesting thing to keep an eye on here, which is, primary elections are base turnout elections. That's been the case since the beginning of time, and there's a reason why Republicans move right in presidential primaries and Democrats move left. And if you look at the makeup of the progressive base, and you think about the candidates that are thinking about running for office, all 2,000 of them on the Democratic side, what you will find is that there is an overwhelming number of them. There are an overwhelming number of them who have embraced a Medicare for all type solution. And I tend to think that that will be a litmus test to a certain degree in this 2020 presidential primary. Now, whether in fact the nominee ultimately ends up embracing that position is an open question, which is not to say that it won't be a significant factor, I think, that will drive some vote choice, particularly in the early states, Iowa, New Hampshire, et cetera. So my view is that this is going to be a major point of contrast in the Democratic primary period. So let's call it roughly, between late 2019 and April of 2020. It'll be a major point of contrast between what the Democrats are talking about and what President Trump will be talking about. And I think the White House sees this as a fight that they're excited to have. I think they feel like that they can win if the terrain that's being fought on is whether to move to a single payer type system or not. And I think it'll be interesting to see whether, here again, the question is, will the more progressive impulses of the left kind of move the debate in that direction, notwithstanding what I think politically the leadership of the institutional left believes is the better course, which is to avoid this kind of discussion in a really earnest way. I just tend to think that the politics of this are going to take over at some point, and the natural inclination of primaries to be the way they are is going to severely affect the tenor of the debate and the nature of the debate.
I agree with most of that, with the beginning statement that Medicare for all means different things to different people. For the president, it means socialized medicine in the Venezuela type of way, or whatever he expressed it as. Other people consider it the concrete HR 676, which is legislation that's been introduced since, it feels like the beginning of time, but it's mostly since the Truman administration, something like that, with John Dingell being one of the first authors of that bill, to being a goal, an aspiration for a simpler, affordable system that is equitable to people no matter where they live. And I think in the next year, we're going to have a whole lot of education and discussion and debate about what is behind this term Medicare for all, and what are the concrete policies and proposals to achieve the goals that the different candidates embrace. So I think it's early to talk about how that education process and how that debate will end in the 2020 election. I also think it's going to depend on context. To the extent that President Trump takes this midterm election and truly does what we thought he might have done on certain issues last year, which is call a truce, sit down with Chuck and Nancy and try to figure out what we can do together. If that's the case, then there might be more energy focus on the bigger vision for health reform. But if instead it is more of what we've seen in the last 24 hours of digging deeper, going harder at these workarounds, trying to, get at Obamacare repeal in an executive branch fashion versus legislative fashion, there may be both more focus in the 2020 election on preserving the status quo and need to do so. I mean, if we are indeed seeing what has been, thank goodness, a stable and insured rate, if that spikes, if costs, not just for people in the marketplace, but in employer-based coverage climb, if we begin to see hospitals closing because states don't expand Medicaid, I think you will have a different flavor of health problems and priorities going into 2020 than it feels like today.
So we're about to open it up to our audience's questions, and so I want to encourage everybody. I'm seeing some questions now, but if you have a question for our speakers, please type it into your control panel, and we'll try to call on as many of you as we can. Before we do that, I just wanted to ask a final question of our two speakers and ask you to help the journalists who are on this call, some of whom are writing for a national audience or national print or broadcast audience, and others who are really regional reporters or state reporters. what approaches would you suggest for them, or what stories should they be doing in their market as you survey this landscape?
Sure, I'll go first. There are, I'm going to call them not sleeper issues, but issues that may be on the horizon in the next year that I think will be interesting and maybe even important in terms of public policy making. We mentioned Medicare for all, but we haven't talked about Medicare as is. The Medicare program, by and large, is still somewhat of a 1965 benefit program. I think there's been some discussion about, is it time to revisit, whether or not Medicare covers things like hearing aids or has a more sensible cost sharing structure. The Medicare program lost 3 years of solvency due to the tax cut bills, change in the mandate, which increased uncompensated care and changed tax revenue. So I think we might see more on Medicare, improving Medicare, than I think people might expect. I also think women's health will become a major topic just because of the conflict that continues between Republicans and Democrats on the topic. I mentioned Medicaid work requirements, but I think there'll be a lot more other kind of discussion about Medicaid. Lonnie mentioned that there is, according to many economists, a risk of a recession sometime in the future. Do we want to revisit proposals like creating a countercyclical Medicaid matching rate? So we have automatic stabilizers in that program. That's something that could emerge as a theme next year as both an economic and a Medicaid policy. And then public health. I mean, I think it always is the stepchild of the health policy debate, yet we have a maternal mortality problem in this country that really needs to be addressed. We have public health infrastructure at the local level that could be strengthened. We mentioned earlier the opioid epidemic. We need more, certainly, in terms of policy attention to ensure that we are not just treating but preventing addiction and the larger set of mental health and behavioral health problems. So I would keep an eye on those policies as well, because I think there may be, outside of the usual battlefield of ACA and Medicare for all, opportunities for progress.
Yeah, and I would say that particularly if the coverage is focused on what's happening at the local and state level, the question of what some states are doing, because there is a lot of innovation that's happening at the state level, regardless of the fighting that's happening at the federal level. And I think there's some interesting questions around how some Medicaid programs are being changed to be more nimble, to be more responsive to some of the trends we're seeing in the labor economy more generally. In other words, how can we create arrangements that might be more flexible for people who are working multiple jobs in the gig economy, for example? And traditional health arrangements don't work particularly well if you're working 6 jobs, none of which provides coverage or perhaps even a subsidy for coverage. How do you account for people like this who are bouncing between, let's say, Medicaid coverage and the lower end of the subsidized spectrum? And I think some states are trying to begin to think about what that looks like. And so I would just encourage people to look at state activity. I would encourage people to think about how the sort of economic conditions that we're facing, the changing nature of labor markets in a lot of these states, how that's impacting people's health coverage and what that means for their lives, because it's very impactful and I think oftentimes undercovered.
Thank you so much to both of you. We have a question from Rachel Kors. She asks, where do you see opportunities for bipartisan cooperation on prescription drug pricing in the next Congress?
Jean, you want to start?
Sure. So it's always hard because the devil is in the details, but starting out with the low-hanging fruit of transparency. The president said he's for it. There's a prescription drug dashboard that we created in the Obama administration that continues. Getting more information, more disclosure, more education, I think, is relatively easy. I think there's also the kind of like agenda to promote generic drugs, preventing so-called pay for delay, trying to prevent all those games and tricks that the brand name pharmaceuticals do to delay access to lower costs. Generic drugs and biosimilars. I think the Part D drug benefit is always sort of been a vanguard of what happens in drug pricing. I expect there'll be a fairly robust discussion about how to update that Medicare drug benefit to align its incentives better to promote lower drug prices. And then the open questions are, will the president, who oftentimes calls himself the negotiator in chief, embrace some sort of negotiation for drug prices? There's a little bit in the proposed rule, or excuse me, advance notice of proposed rulemaking that he put out in the Part B drug program. There could be more there. But I think there's a whole range of proposals that I think is just a sample.
Yeah, I think that's right, and a lot of this is really where the details are. You know, the president did appear to embrace, for example, some element of taking what's happening on pricing in foreign markets into account with respect to pricing here in Medicare, and you know how seriously we ought to take that, or whether that would be something that would have an audience for statutory change in Congress, that remains to be seen. I would just say that the nature of the Republican coalition is changing. And previously, you know, if you'd asked this question, let's say even, you know, I'd say 5 years ago, the answer you would have gotten would have been different in terms of what Republican tolerance is for policy solutions that seem a little more aggressive if you're thinking about how they affect the marketplace. And I would say that that's changed. I think what's changed is the nature of the opioid epidemic, the rising price of prescription drugs, or the perception around that, I think has been incredibly powerful. And a lot of Republicans just have a fundamentally different approach toward market-based economics now than they used to. And so I think the coalition and constituency for some more significant government intervention in the drug pricing space, the appetite for that, I think, is greater now amongst Republicans than at any point in recent history. Which is not to say that something's definitely going to happen. It's just to say that the traditional alliances that we've seen, where Republicans were very much making the argument that, you know, any kind of move toward price controls, or any kind of move toward something that looked like a price control, would be problematic for innovation and therefore should be opposed. I think that point of view is beginning to shift a little bit.
And I would just add, watch the House Oversight Committee, because I think there's going to be a fair amount, going one step even shorter transparency, a fair amount of focus on what is going on inside the drug industry from that committee. And I think there'll be, you know, that would, I think, undergird some of the energy behind this issue as well.
So we have a question from Jackie Fortier. She says, I'm a reporter in Oklahoma, a state that has not expanded Medicaid. We have the second highest uninsured rate in the nation. U.S. House reps say that it's up to the state to fix, but the state doesn't have any money. Is there an effort on a federal level to secure funds for red, non expansion states to perhaps provide more subsidies, but that falls short of the Medicaid expansion? Is there a plan?
There's one, and I think I'm hoping that there might be more in the next Congress. So I'm looking for the bill number, but there is a bill that would say to states like Oklahoma, if you newly expand in hypothetically 2020, you will get the same deal that a state that expanded in 2014 got, which is 100% federal funding for the first 3 years, phasing down over time to 90%. So it's a jump start on the financing for states that are interested in expanding. Previously in the ACA, it was tied to actual years, 2014, 2015, 2016. I also, here at the Century Foundation, did a paper on 5 other options that Congress could consider to support and or cajole states that are interested in, or that have not yet expanded Medicaid, because I think the idea of waiting and hoping for election changes is not satisfying to a lot of people on the ground in states where there's not an immediate prospect for it. I expect the coming Congress will begin to talk more about these ideas. Whether or not they act on them, it's not clear. It's not clear the Senate would take them up or the president would sign them into law. But in my experience, you know, we got the Affordable Care Act passed in 2010 because of all the work that happened between 2006 and 2007 with the midterm change in Congress and all the effort, energy, coalition building, evidence building happening in that period of time. So I'm hopeful that for the Medicaid expansion, that's the case going forward as well.
Yeah, you know, Oklahoma is an interesting case because the state had actually put together a quite robust plan for 1332 waiver, or using 1332 waivers in part to address some of the questions of uninsurance and affordability that the questioner has. It was probably actually the most forward-looking proposal of any state that I saw, certainly on the market-based side of the ledger, in terms of actually putting together a comprehensive set of ideas to address the challenges of uninsurance and of healthcare cost all through the income spectrum. Whether that sort of vision is achievable even under an administration that is more likely to approve a broader waiver is an open question. But I do think some of that thinking is critical, in the sense that if Oklahoma can figure out a way to put together a plan that allows it to leverage that federal source of funding in a way that they can use it to expand coverage, I think that will be an interesting case. As I said, very forward-looking. Unlikely that, given the current guidance, even what Oklahoma has proposed would fit. But I do think that it's worth going back and digging up this paper that was put out by the task force that Governor Fallin had put together, that tries to address some of these questions of uninsurance and affordability in a really coherent and what I think is quite thoughtful way.
We have a question from Mary Ellen McIntyre with Congressional Quarterly. She asks, what are you both looking for in the lame duck session? Does the House flipping increase pressure for industry groups to push their priorities this year? And she says she's thinking about the donut hole, Part D fixes, creates, or certain ACA taxes.
Yeah, I mean, the end of the year is always a little bit of a rush anyway, and certainly I think some of these ACA taxes, the HIP tax and a few others, are always kind of swimming around as fodder for activity. Yeah, I mean, I tend to think that they will probably do a few things in the lame duck relating to particularly the ACA taxes. The donut hole, I'm not as sure about, but certainly it would seem as though the flipping of control, I think, does put some pressure in terms of industry groups wanting to get more done now, because they always prefer predictability to unpredictability. And the change of control in the House means a more unpredictable 2019 agenda. So in that sense, I think if they can get stuff into this end of the year package, they probably will want to do that. But in terms of more specifics, I don't know, maybe Jean, you've got some thoughts on what might happen.
I don't have any more thoughts on the specifics. I would say generally about lame ducks, Pew Charitable Trust did a little analysis that I found interesting. In 2010 lame duck, 99 laws passed, representing 29% of the substantive output of that lame duck, of that entire congressional session. And I remember that because that was the midterm in which Obama had lost his Democratic control of the Congress, and it included things like modifying the tax cap reconciliations and the premium tax credits, a bunch of repeals of parts of the law that were like technicals that people needed to get fixed. Similarly, in 2012 lame duck, 87 laws passed. So it's a time when things happen. Whether or not they happen this time does depend on the dynamics, but as a reminder, there's a whole lot of so-called extenders that expire at the end of next year. So I think everybody's eyeing not this lame duck, but next December as the big legislative year. So for example, the big Medicaid disproportionate share hospital cuts go into effect in 2020. The Community Health Center Fund expires, or there's no new amounts being given to that fund at the end of the year. There's a physician fee schedule zeroing out the update in that year. So there's a bunch of things that are not hot health policy. They're not big and ideological, but they're sort of must-dos for Congress. So I would anticipate that may be the moment for many of these things, not this December.
We have a question from Stephanie Innes of the Arizona Republic. She says, is the Texas versus Azar case something that could change U.S. healthcare in the future? And if so, what should reporters watch for? And let me just add, some of this depends on timing. So, how do you think this might play out, and when might there be some serious consideration?
So the judge in Texas had his hearing on September 5th. We're waiting for his decision any day. As a reminder, 20 states originally sought a preliminary injunction of the entire law effective January 1. So the clock is ticking. At that hearing in September, the government argued, wait until after the end of open enrollment because it could scare people off and they may not sign up for coverage, they may be confused, which is an interesting argument, but we don't know if the judge is going to adhere to that. But we will get that decision. It is likely that the attorneys general who've intervened in this case and are protecting the law would appeal an adverse decision. So it would go to the Fifth Circuit. The Fifth Circuit also is a fairly conservative circuit, so it could be that they uphold an adverse ruling at the lower courts, and I can imagine this case could get to the Supreme Court at some point in time. But it's all contingent on, does the judge in the first round, the appellate court, or the Supreme Court stay an injunction? And that's something that we're all watching, because if not, I mean, the worst case scenario is the attorneys general, several of whom got elected to the Senate, or excuse me, one of whom got elected to the Senate, prevail, in which case the whole law is enjoined immediately, which would have devastating effects to the healthcare system as the full range of stakeholders express an amicus briefs for the case.
Yeah, I mean, I'm a little more skeptical about the prospects for the lawsuit. I do think there are some novel questions of administrative law and less administrative law, I guess, more with respect to the question of severability around the statute that constitutional law geeks kind of find interesting, but fundamentally whether those questions are significant enough import to make it to the Supreme Court, we'll see. But I tend to have a less doomsday vision of kind of where this is headed.
And I have one final question for both of you from Sheldon Weisgrau, who says, what advice do you have for media covering work requirements and other barriers to coverage? How can reporters cover the nuances fairly?
So it's a great question, because each one of these state waiver applications is different, both on what the worker community engagement requirements entail, how the reporting works for individuals subject to them, what work supports are in those programs, and who is exempted. So I think folks have tried to do, I think at Kaiser Family Foundation and MacPac, who actually said do a pause on these until we evaluate its effects, have tried to do kind of like a framework to take apart what are these different applications in terms of the right questions to ask of work requirements and what do they mean. But I think going beyond that, one thing that I think hasn't been covered well is each one of these waivers typically includes other elements, like lockouts for people who don't pay their premiums for a certain number of months, or significant copays or premiums for people below poverty, or in the case of the original Wisconsin 1115, drug testing requirements to be eligible for Medicaid. That got changed in its final approval, but each one of these is not just work, but it's also other things. And I appreciate the fact that there's probably not one answer to how to report on them fairly, but digging in and figuring out these pieces, and secondarily looking at the impact. The judge who stayed the Kentucky waiver asked the basic question, is this about reducing coverage, which is not the goal of the Medicaid program, or not? And I think we've seen in the Arkansas waiver, which did go into effect, 4,000 people lost coverage each of the first 2 months that it was implemented. And is that because they're struggling with this new system, or is it because they're people who didn't want to work and didn't want Medicaid? And so I think that looking at the impact as well as the structure of these waivers is an important thing.
Yeah, and I would just say that I think part of fairly covering it is really getting at what the rationale is, right? Talking to the policymakers and saying, look, what is the rationale for doing this? And, I think speaking to motive is important in this case, because to Jean's point, it's one thing, and I would be surprised if the answer that they would give you would be that, the goal is to reduce coverage. I think the question really becomes, what is the purpose of tying something like work requirements into a program that's never had them before, and it's never been a part of becoming part of, being on Medicaid? And so what's the rationale? What's the policy reasoning for it? and really getting at that and trying to represent that fairly. I think that's the best that advocates can ask for, quite frankly. Advocates of that kind of policy can ask for is to say that their point of view was represented and to get at what the impact of that point of view is and whether in fact there are people who for some reason were not deserving of being on the program that have been found out to be on the program. What does that mean? I think covering that fairly requires an articulation of what the justification is from a particular administration.
I'd like to thank our two distinguished speakers for this thoughtful conversation. We're going to conclude our webinar, and I just wanted to share that we will be sending all participants a quick survey and ask you to share your views of what you just heard as well as your ideas for future webinars. That influences us a lot. And I also wanted to let you know that the video of this webinar will be available online a little later today. Thank you very much and have a great day.